problem of HIV infection in Uganda started where early in the 80s, but kept growing so that by the early 90s, it was a very big problem in the country. The people were very scared. They were afraid to be associated with it. They didn't want to talk about it. They went underground, went to traditional healers, and even many doctors and other health workers couldn't help them much.
At that particular time, there were probably something like 10 or 12 million HIV positive people in Africa, of which, if I can recall, there was only something like 500 patients were receiving antiretroviral drugs. I was appointed by UNAIDS to be their first negotiator with the multinational pharmaceutical industry to secure access to antiretroviral drugs in Africa. When we started to involve the pharmaceutical industry, the questions they were asking was all about security of supply, security of distribution for their drugs, insurance that the patients get the drugs of high quality on time. We had to put together kind of a one-stop shop, I'll put it that way, where there would be a world-class procurement, supply chain, management activity.
The pilot project known as DAI, Drug Access Initiative, started as a small project without even a proper office. So I would say that we were sharing an office, we called it the corridor office, and we were all cramped in there, the supply side, the public health side, and the secretary, and CDC that was dealing with data, were all sharing more or less one office within the UNAIDS office. So Wade, who was handling it, was very determined that it has to work.
Our first car was donated to us by Glaxo Wellcome, at a time a very old Nissan Primera that eventually they sold to us at $1. I was my own secretary, I was my own accountant, I was the general manager, I was a driver, I would go to the office to bank, I would pick the drugs from the airport and drive them to the container. And I would deliver them to JCRC or to Mbuya Military Hospital. I was hired at a time when the pharmaceutical companies had just discovered antiretroviral therapy. So I saw great opportunity for the organization and medical access to make a difference in the lives of people living with HIV.
When the UNAIDS Drug Access Initiative was announced, there was some hope in the country because at least we saw that few drugs were going to be able to come to Uganda under the Drug Access Initiative at a lower price. And then also we're able to induce few changes in the Ministry of Health situation to see whether we could be able to put some of these drugs in a few paying hospitals. And at the same time, the Drug Access Initiative was able to negotiate for lower prices.
At the end of 2003, there was an announcement that there would be an initiative to get access to free medicines through PEPFAR, funded by the US government. On the 19th of February 2004, we received that letter that stated that we had access to money now to start patients on antiretroviral drugs for free. Within 6 months, all the patients that used to be lying down on small pillows and mattresses in the waiting room, they were all seated up every time they came for review. So it was like people who had died had resurrected and now they were seated in the reception area of the facility.
In 2006 is when I started talking to my patients in this clinic, in this hospital here in MAUL. When they were not, because of stigma, they were not swallowing their drugs properly. Some of them were hiding. I somehow sort of started bearing myself, telling them, look, I'm swallowing these drugs myself. I'm on ARVs. Sometimes I had the habit of swallowing the drugs in front of the patients to show them that I was swallowing the same drugs. So actually, as far as fighting stigma is concerned, this program helped a lot because AIDS was looked at as a death sentence. When there's somebody who was like me, who was very sick with AIDS in 2000, now I'm okay.
Yes, Maria Street, how are you? I'm trying to follow up again. You indicated that you have a global scarcity of Z30. We placed our orders in time, we forecasted in time, but there have been these delays, so we are a little bit concerned. Yes? Yes, but no, it cannot be, because if you push the orders up to April, then we will have run out of supplies. If you can give us 50%, we shall really appreciate.
The Karamojo region has a very mobile group of patients who daily are faced with the challenge of, do I stay on ARVs or do I take care of my cattle, which is my basic means of survival? So most of the times they move looking for water and pasture for their animals. So being on life-saving ARVs becomes a second option or alternative. But you want those patients, or as many as possible, on HIV drugs for the rest of their lives. And also you want those who are on HIV drugs to maintain so that resistance does not develop. What we did, because these are regions that have rainy seasons or wet seasons that spell for 5 to 6 months, which normally cut off transportation to them, we were faced with having to make our forecasting systems for these particular facilities a bit flexible. So instead of quantifying for them for 2 to 4 months, we had to stretch it as far as possible, like 6 months, so that for those that can be available during the 6 months of the wet season, they have sufficient supplies.
Sometimes we face challenges on our routes to the facilities. You find when the roads are flooded, the flying stones from the top of the hills coming down forces us to be very early in the morning, even if we go long trip to reach the facility, but we always reach and deliver the drugs.
When we took on this project, we had about 39,000 patients. Gradually, this number grew until the current date, where we have about 288,000 patients. So along the way, the number of IPs increased from 3 IPs to 14 IPs. And the number of sites increased from 18 to 218 sites. So this increasing number meant that we had to increase our warehouse space. And we felt that at this point we needed to get a home of our own, where we could build a state-of-the-art warehouse with all the necessary amenities that are essential for warehousing pharmaceutical commodities. It features a lot of standard recommended WHO practices, 24-hour security surveillance systems, CCTV cameras. We have a cold chain system that has 116 cubic meters. This is very large compared to the needs of the program. The benefit of the barcoding system was to enable us efficiently receive, put away, and warehouse commodities in the shortest time possible. The barcode system also enables warehouse personnel to be able to trace commodities during stock count or during retrieval or replenishment of commodities. Facilities can electronically sign on our PDA machines, and then we receive the information real time.
There should be visibility of what is happening at all points. MAUL's immediate plans are to implement what we call a 360 degrees supply chain data visibility through a system now internationally known as VAN, Visibility Analytics Network. This implies that you should be able to see from the supplier to the client. We have established a system called SAP MIP that has the visibility of stocks that the suppliers are going to deliver through our e-procurement system. We have established systems to manage the inventory when it comes to our warehouses, and we are again implementing electronic inventory management systems at facilities in order that we can be able to assist facilities to manage this inventory. So we are linking or interconnecting these systems so that we can be able to create an intelligent network. The advantages are several, but include the biggest one of ensuring consistent availability of these products, of health commodities at the place where they are required.
We are privileged to enjoy the installation of an online ordering system. When we're sitting here, we're punching in stuff, Medical Access can see what we're doing, so they know what is running out. They'll prompt you, this looks like you're going to need this, which makes life so much easier for the staff. It gets real-time response to our needs. We receive commodities between 3 to 4 million USD every year from PEPFAR through Medical Access. I can tell you, if I ordered commodities at 9 a.m. today, by 2 p.m. I would have everything that I asked for. And it means our patients are sure that if they come to us and it's a commodity they need from Medical Access, we will have it.
Medical Access implements a custom-designed mentorship and technical health system strengthening model that addresses the unique challenges the health facilities that we support are facing. Through this approach, we have been able to train, mentor, and supervise health facilities for them to improve their commodity management practices.
Medical Access has been instrumental in supporting us with capacity building, and as a result of that, we've never had any stockouts because we know how to forecast and we know how to order for medicines and maintain the number of quantities that we need. Because of their love for clients, we've been able to improve our services, and we are achieving the 90-90-90 UNAIDS goal because of the support and the partnership.
I want to say together with MAUL, with you, because it's not just MAUL, it's the partnership that's represented in this room today. We have made tremendous progress, and I look forward to us stopping this HIV epidemic, treating this disease. We have had assessment after assessment where we have looked at the price and the reliability of the systems that MAUL has delivered, and they have always exceeded our expectations and beat global giants.
At the beginning of the year, we solicit for proposals of how we can support the communities in which we serve. Under the Restoring Hope initiative, which was initiated in 2009, we usually get quite a number of proposals. When we get these proposals, we sit as a team and do a thorough analysis and see where we think our contribution will have a great impact.
If PEPFAR can come in and support fellow Ugandans, we also feel that even us as Ugandans, this is one way we can give back to society. This is one way we can make a contribution. So we have supported programs ranging from refurbishment of pharmaceutical warehouse, supporting orphanage homes.
They have also joined us every year to commemorate Patient Solidarity Day, to raise awareness on the critical role of patients, families, and community on how patients can get more involved, empowered, and engaged to improve the healthcare outcomes. And indeed, this interaction has provided an opportunity for Medical Access to interact and understand the needs of patients, and also being able to design appropriate solutions.
Tuli mu home care nga abalina akawuka ndi positive. Twali mu 2016 nga tutandika ekibiina kino nga tetulina ddagala. Abantu baali beekweka nga tebasobola kuvaayo. Ne tukola omulimu gw'amaanyi nnyo okubajjayo. Twamala okubajjayo ne tubaleeta ate eddagala nga tetulina. Mu famire yange n'akafiirwa baganda bange 7 bampanga transport ya mutwalo gumu n'ekitundu n'entwala abalwadde 14 nga mbatwala ku JCRC. Naye nga tugenda ku saa 12 tuvaayo ssaawa emu ez'ekiro naye nga tewali RVs. Abantu ne bafa paka lwe twasisinkana ba Medical Access. Okuva olwo Medical Access kasita yatuuka bannange tufuna eddagala lyaffe mu bujjufu. Medical Access twagala nnyo, mwebale nnyo, mwebalire ddala, mwongere amaanyi era naffe tujja kwongera okubuulira abantu ekirungi ekiri mu ddagala.